Today, we're going to review the new guideline for benzodiazepine tapering. Now, this guideline was published March 3, 2025 by the American Society of Addiction Medicine. This guideline provides information on evidence-informed and consensus-based strategies to help clinicians determine whether tapering benzodiazepine, also known as BZD medications, may be appropriate for a given patient, and if so, how to taper them. For the full summary of recommendations, make sure to check it out on guidelinescentral.com. Now, the first three recommendations focuses on tapering benzodiazepines. For the first recommendation, clinicians should ideally assess the risks and benefits of ongoing BZD prescribing at least every 3 months for each patient taking BZD medications. At a minimum, clinicians should assess the risks and benefits with each new BZD prescription or BZD prescription renewal. Clinicians should review the information in the relevant prescription drug monitoring programs as part of the risk-benefit assessment. For the second recommendation, clinicians should avoid abruptly discontinuing BZD medication in patients who are likely to be physically dependent on BZDs and at risk for BZD withdrawal. Tapering is indicated for patients who are likely to be physically dependent when the risks of BZD medication outweigh the benefits. Clinicians should consider either discontinuation or a short taper for patients who are unlikely to be physically dependent when the risks of BZD medication outweigh the benefits. Now for the third recommendation on tapering benzodiazepines. If the BZD medication is discontinued without a taper in patients who are unlikely to be physically dependent, clinicians should counsel patients to report the emergence of withdrawal and/or rebound symptoms. If significant symptoms emerge, clinicians can consider using medications for symptom management or restarting the BZD medication and initiating a taper. The fourth recommendation on partnering with patients. Clinicians should develop the BZD tapering strategy in coordination with patients and their care partners in a shared decision-making process whenever possible. The fifth recommendation focuses on level of care. BZD tapering can typically be managed in outpatient settings. However, clinicians should consider inpatient care for BZD tapering when patient presentation indicates an imminent risk for significant harm related to continued use of the BZD medication that is unlikely to be rapidly mitigated by the initial dose reduction of the BZD taper. Patient symptoms and/or co-occurring physical or mental health conditions are anticipated to complicate BZD tapering in a way that cannot be safely managed in an outpatient setting. The patient is experiencing or imminently anticipated to experience severe or complicated BZD withdrawal. Recommendations 6 through 9 are on the tapering process. Recommendation 6 states that clinicians should generally consider dose reductions of 5% to 10% when determining the initial pace of the BZD taper. The pace of the taper should typically not exceed 25% every 2 weeks. For recommendation 7, clinicians can consider transitioning patients without contraindications to a comparable dose of a longer-acting BZD medication for the taper. For recommendation 8, clinicians should tailor tapering strategies to each individual patient and adjust the taper based on a patient's response. And recommendation 9 states that clinicians should evaluate patients undergoing tapering for signs and symptoms related to the BZD taper with each dose reduction. Recommendations 10 and 11 are on adjunctive interventions. Recommendation 10 states that clinicians should offer patients undergoing BZD tapering behavioral interventions tailored to their underlying conditions or provide them with referrals to access these interventions. And recommendation 11 states that clinicians should first consider pausing or slowing the pace of the BZD taper when patients experience symptoms that significantly interfere with the taper. However, clinicians can also consider use of adjunctive medications. Recommendations 12 through 15 focus on the management of severe or complicated withdrawal symptoms. Recommendation 12 states that clinicians should manage patients experiencing severe or complicated withdrawal in inpatient or residential medically managed settings with monitoring for signs and symptoms of BZD withdrawal, including regularly measuring vital signs and using structured assessment tools. Assessments for seizure risk, managed as appropriate. For the 13th recommendation, it states, tapering with very long-acting agents such as phenobarbital can be considered for BZD withdrawal management in inpatient settings. Should only be conducted by or in consultation with clinicians experienced in the use of these agents for the purpose of BZD withdrawal management. For recommendation 14, Clinicians should avoid rapid BZD reversal agents such as flumezanil for the purpose of BZD tapering due to risks for refractory seizure, cardiac dysrhythmias, and other adverse effects. And Recommendation 15 states that clinicians should avoid general anesthetics such as propofol or ketamine for the purpose of BZD tapering. On to Recommendations 16 through 18, which are on patients co-prescribed benzodiazepines and opioids. Recommendation 16 states, because patients co-prescribed BZDs and opioids are at increased risk of respiratory depression, clinicians should assess the risks and benefits of continued BZD prescribing at least every 3 months, or with every related clinical encounter or prescription renewal, whichever is more frequent. Then Recommendation 17 says clinicians should offer to provide or prescribe opioid overdose reversal medication for all patients co-prescribed BZDs and opioids. And Recommendation 18 states that clinicians should consider additional strategies for mitigating risk, including using the lowest effective doses of BZD and opioid medications and optimizing non-opioid interventions. Recommendations 19 through 23 are on patients with benzodiazepine and other substance use disorders. Recommendation 19 states that clinicians should consider more frequent assessments of the risks and benefits of continued BZD prescribing for patients with co-occurring SUDs and/or other co-occurring addictions compared with the general guidance in Recommendation 1. Recommendation 20 states that when tapering BZD medication in patients with SUD, clinicians should manage the underlying SUD concurrently with the BZD taper. For Recommendation 21, clinicians should not use BZD prescribing or tapering considerations as a reason to discontinue or disrupt a patient's medications for SUD treatment, including buprenorphine and methadone. Recommendation 22 says that, following the taper, clinicians should continue to monitor and treat any underlying SUDs, or refer patients to an appropriate level of care for continuing care. And with Recommendation 23, clinicians should offer patients harm reduction services or provide them with referrals to access these services. Clinicians should offer to provide or prescribe opioid overdose reversal medication and provide or refer patients for related education. Clinicians can consider providing or referring patients to community services for drug checking or other safe use supplies and related education. Recommendations 24 and 25 go over patients with co-occurring psychiatric disorders. Recommendation 24 states that clinicians should strongly consider tapering BZD medication in patients with post-traumatic stress disorder. And Recommendation 25 states that clinicians should monitor sleep closely during BZD tapering in patients with mood or psychotic disorders, particularly for patients with bipolar disorder, as sleep disturbance can trigger episodes of mania. If patients with a mood and/or psychotic disorder experience significant sleep disturbance, clinicians should pause the taper until the symptoms resolve due to the risk for destabilization. Recommendation 26 is on older adults and states that clinicians should generally taper BZD medication in older adults unless there are compelling reasons for continuation. Finally, Recommendations 26 and 27 are on patients who are pregnant or lactating. Recommendation 26 states that clinicians should weigh the risks and benefits for the maternal-fetal dyad when considering continued BZD prescribing or tapering for pregnant patients. And last, Recommendation 27 states that for infants who have been exposed to BZD in utero and are at risk for neonatal withdrawal, clinicians should encourage breastfeeding, which can reduce neonatal withdrawal symptoms. Communicate with the infant's healthcare provider, with parental consent, regarding exposure to BZDs. So there you have it. This has been a recap of the new Benzodiazepine Tapering Guideline published by the American Society of Addiction Medicine. For more information on this guideline or to access the summary or other resources, visit us online at guidelinescentral.com or download the Guideline Central mobile app available on iOS and Android devices. This has been a Guideline Central production, and we'll see you very soon for the next one.